Welcome to Behind the Scope, Empire Urology Clinical Case Conversations. I'm Dr. Alex Small, Assistant Professor of Urology at Monefiore Medical Center, and I'm joined by my colleagues, Dr. Christopher Anderson and Dr. Gina Badalato, both Associate Professors of Urology at New York Presbyterian Columbia. This podcast, sponsored by the New York section of the AUA, aims to take you through the key clinical decision-making and technical aspects of high-yield urologic cases. We'll present hypothetical cases that highlight experts' differential diagnoses, preparation strategies, treatment recommendations, and thought processes. Each episode will guide you through the step-by-step evaluation and management of specific urological conditions, emphasizing relevant clinical guidelines and featuring a variety of guest experts. So join us as we explore the complexities of urological care and deepen our understanding of clinical practice together. For our first episode, we are joined by our colleague and friend, Dr. Jared Winoker, Assistant Professor of Urology at Lenox Hill, part of Northwell Health. He's the Director of Endourology and Associate Residency Program Director.
Thanks so much for having me today. It's a wonderful opportunity, and I want to commend you on yet another invaluable educational initiative by the New York section and the Empire Collaborative.
For our first case, we're going to be focusing on kidney stone disease. The case is a 47-year-old man with intermittent right flank discomfort. He has a non-contrast CT scan that shows a 1.5 centimeter right-sided lower pole renal stone with a density of 950 Hounsfield units, no hydronephrosis, and no evidence of infection. His creatinine is 1, he has no prior kidney stones, and he has a pending 24-hour urine collection. Dr. Winoker, what additional information would you like about this patient as you decide on his management?
Great. So, like any patient, of course, we want to start off with a comprehensive medical surgical history, certainly being mindful of that comorbidity. Are they even a surgical candidate? Obviously, I'm going to focus in on that GU history with a particular emphasis on the stone history. I'm going to want to know things like, have they had prior treatments and past stones? That may tell me a little bit about what their experiences were, and therefore I'll start to get a sense of what management approach they may favor. Certainly, I'll want to know the medications they take. Things like anticoagulants, antiplatelets are, of course, important to know. I do like to know their social history, occupation, frequent travelers. Maybe there's someone who just, in general, has poor access to care and therefore may not be a good candidate for surveillance. And of course, I'm going to have a thorough, at least focused physical exam and a careful personal review of their available imaging.
Thanks. Well, this gentleman fortunately is healthy. He takes no medications. He's never had surgery before. He's never had any kidney stone episodes before. He works as a doorman on the Upper East Side, maybe around the corner from your hospital. So he's got plenty of access to care. And he's fairly bothered by this kidney stone. It's causing him intermittent flank pain. On your exam, he does have some mild CVA tenderness, but it's tolerable. He controls it with the occasional Tylenol, and he's very nervous about surgery. So how would you counsel this patient on the options of observation versus intervention for this kidney stone?
So to treat or not to treat really is that ongoing debate without any resolution in sight, especially when you're talking about these, conceivably non-obstructing stones. In a case such as this one, where there isn't really an obvious absolute need for treatment, the patient is having some intermittent symptoms, and there's some question about whether that's really from the stone or not, and we can touch on that shortly. But obviously, there's no obvious evidence of obstructive processes, infections, renal compromise. So, I'm going to place a pretty heavy emphasis on the patient's personal preferences and ultimately, goals for determining whether, use that as for the goals for determining whether we're going to observe or just intervene. And that decision will really come from a thorough discussion of the relative risks and benefits, as with any treatment counseling.
What do you tell them the risks are of observation?
Yeah, so, as I'm alluding to, observation is a very reasonable approach here, but there are risks. Notably, we do worry about stones passing and causing obstruction down the line. Invariably, a patient's going to ask you, well, what are the chances? And that's a difficult question for all of us to answer because there's just a relative dearth of data, and what's out there is kind of poor quality. It's mostly retrospective in nature. I think if you look at those wide-ranging risks, you may often fall somewhere in that 20% over 5 years. I think it's a pretty safe estimate that a lot of people we'll touch on. But ultimately, they just have to accept that there is that inherent risk. And that has to really be contextualized by the size of the stone. That is, we can use the size of the stone to prognosticate the ability to successfully pass a stone should it move. And that may also help them kind of shift their decision whether or not they want to treat or not. Other risks are, of course, stone growth, in addition to obviously making future treatments more challenging and lowering the risk of successfully clearing their stones. There is the possibility that such larger stones can internally obstruct. We typically think of like staghorns and partial staghorns internally obstruct. But even these typical calyceal stones, when they get large enough, they can obstruct at the level of an infundibulum. So in this case, the lower pole infundibulum, which may be why he's having intermittent pain. You may notice that on imaging with some focal calyectasis or even some focal thinning of the parenchyma if it's been chronic. So really, what it boils down to is, does this patient want to take the known discomfort and inherent risks of a treatment, or settle for the unknown? And to me, that's really something that can only be answered by the patient.
Absolutely. In my practice, I find that the patients who have passed a kidney stone before are very eager to never, ever have that experience again, and they tend to opt for treatment. The patients who have never had the pleasure of that experience are much more willing to opt for observation until it starts to move.
Yeah, and that's where history is so important. It's just getting that prior kidney stone history.
Now, you mentioned, it's important that the stone is in the lower pole, hydronephrosis, the infundibular diameter, perhaps. What other anatomical considerations do you take into mind when approaching a patient like this?
Yeah, so touching a little bit of what you're saying there, and I'll just kind of elaborate. So, certainly that angle to the lower pole, in the literature, we call this the infundibulopelvic angle. So a very acute angle is going to make treatment difficult. We've all done those very inferior lower pole stones where you can barely even see the stone. So your success of treating it's going to be challenging, or even leaving residual fragments just by the nature of gravity in there. Other things that we may be concerned about are the relative caliber of the ureter, especially at the UPJ, the infundibulum into that lower pole. And then there's the host of all the things we will see from time to time, complete or partial duplications, high inserting ureters. There's just a variety of things. That's where, pre-op imaging is just going to be so critical for that decision making.
The patient in this case has already had a CAT scan. Do you obtain any additional imaging, or?
Yeah, I think a CAT scan here is going to be sufficient. I will get a CAT scan on pretty much any patient who's considering a treatment. If you were really go by the book of the guidelines, they would say they would strongly recommend a CT, of course, for someone undergoing a percutaneous treatment, but they'll have a little bit of a softer recommendation on, you could consider one for the other options I'm sure we'll get into. But I will not need a further image here. I would say if there was some concern for, like a diverticular stone or some kind of level of internal obstruction, I may even get a CT urogram, but that's more the exception than the rule.
Great. Now, can you walk us through sort of the three major treatment options for this patient?
Yeah, so broadly speaking, you're considering your shockwave lithotripsy, your ureteroscopy, and your PCNL. So, beginning with shockwave and kind of just going a little bit through the spiel of how I often will explain it to patients. Of course, a shockwave is the least invasive treatment in that nothing is physically going inside someone. I will counsel the patients. That doesn't mean it is the lowest risk by any stretch. You can still have hematomas and bleeding from it. It's just people are often very bothered at the idea of something inside of them, particularly stents. So that's sometimes where it's an option. And of course, what we're doing is we're relying on the sound waves to effectively fragment the stone into small enough pieces, then relying on the natural flow of urine to pass it. But of course, because it's non-invasive, there are just certain things we can't predict, and that kind of is baked into the somewhat substellar stone-free rates compared to the other modalities, I would say. We were talking, like you brought up the point of imaging, like you can look at the density in the Hounsfield units, which may tell you, but it's a little still hard to know the exact composition of the stone. And we know that some stones are just very dense and going to be refractory to stones. So that's an important consideration. Obviously, if they fail the treatment and still want treatment, or God forbid, they have a lot of fragments that get stuck, they're still going to likely end up needing a ureteroscopy and a stent. But I think the glaring thing here, hopefully anyone listening realizes, well, this should be like, if you're taking your in-service exams, like greater than 1 centimeter lower pole, like this is immediately like one of those things that you're going to give a little pause to and really counsel that patient carefully. That doesn't mean it's off the table. The guidelines will say they should not be offered a shockwave as a first-line treatment. That doesn't mean it's not possible. And that's where patient preference is critical. They say, I'm willing to accept that it may take multiple treatments or that it may fail. Maybe their goals of their care are just to reduce the maximum size of the largest stone, and then they'll deal with passing whatever. And then, then you roll with the shockwave. So that's really how I approach it. The ideal stone is not too dense on the Hounsfield units. It's ideally a solitary stone, because you can really only treat one stone for the most part at a time, and there's no concern for a distal obstruction or something like that.
Yeah, those are great points, Jared. I appreciate that you kind of highlight the real world approach versus the guideline recommendations, especially in a case like this where you're sort of in a bit of a soft zone, sort of an in-between zone.
So, Jared, we not to veer too far from our initial patient, but when do you actually find that Eswal is a good treatment for kidney stones? Which patients do you tend to be Eswaling more of now? And when are you actually recommending that, perhaps more than some of the other treatment options?
It's a good question. I will say, just out of personal practice, it's very rare I'm outright recommending a shockwave. The data really shows that, particularly for the less invasive, like a ureteroscopy, it tends to be superior. Ureteral stones is a different discussion, like proximal ureteral stones, but like larger stones in the kidney, a lot of the data still really supports ureteroscopy. And I just feel that a lot of the older data where it showed that the outcomes are not that dramatically different, I just feel like that's the older outcomes where the technology wasn't there. So I do very few shockwaves, and usually it's a patient who comes to me requesting it. Or I will maybe lean them towards it if really, like, for example, they have a history of like one of those horrific stent symptoms, someone who's just not going to tolerate a stent. It's going to be way worse than the treatment itself. And that may be it. And also a case where there's like a solitary stone that's not too large. I think if they're having multiple stones, and a lot of people are coming in with the goals of care of like, they want to be stone free after a single treatment, that's never going to happen after a shockwave if you have multiple stones.
Right. And so practically speaking, if you were to do a shockwave on somebody, you would not also put a stent in that patient either before or after the procedure?
No, I wouldn't. It's an important point you make. It's one of those, I definitely did that when I was back in training. And I think it's one of those dogmatic things we used to see that way. They would say, like, for a larger stone, more likely to have fragments, they would preemptively put it in. They've studied this. It doesn't really change the outcome. I think it was actually Dr. Preminger had one of those seminal papers that really showed the only difference is that there was a poorer quality of life in the patients who were stented. So the adage in our subspecialty is that if you're thinking you need to put a stent in preemptively or preoperatively for a shockwave, you probably need to be doing a different type of treatment.
Right. That's a great point. So, getting back to our, 1.5 centimeter lower pole stone in this patient who has some symptoms. So you and him decide that he is going to proceed to have an operation. You talked to him about ureteroscopy and PCNL. What kind of helps you decide which one of the two of those approaches to take, and which one would you recommend in this patient?
It's a great question, because we're really, the case is very well chosen here, that this is really one of those true, like, on the fence in terms of size. It's not an accident. The first thing, of course, is desire to have a complete stone-free result in a single stage. I think right now, and we can touch on newer technologies and things that are exciting, but as it stands right now, we have randomized trial data that shows that stones in the 1 to 2 centimeter range have a far higher success rate with a percutaneous procedure compared to ureteroscopy, albeit it comes at the expense of the morbidity and the risks of the procedure. And then, referring back to our guidelines in this stone range, it's very clear that when you're at 2 centimeters and larger, the guideline panel is like, yeah, that should really be where a PCNL is considered. Less than a centimeter, you're thinking ureteroscopy and shockwave, but they're not very firm in this 1 to 2 centimeter range. And I think it speaks a lot to what is the surgeon's comfort and the number of cases they do. This is probably someone where lower pole location, I probably would favor a percutaneous procedure for this patient to try and render them stone free, be done in one shot for those reasons.
So let's hypothetically say he's got anatomy that wouldn't lend itself to a percutaneous procedure. Maybe his colon's in the way, or horseshoe kidney, or you name it. How would you tackle this ureteroscopically? What are some of the instruments that you would have at your disposal? How would you counsel the patient about what to expect during and after the surgery? What would you get in the room, and how would your general approach be?
Yeah. So obviously, starting at the level of the preoperative counseling, this is a patient that has to understand that there are going to be limitations of the ureteroscopically, of the ureteroscopy with regards to stone clearance. So it's someone that if they are truly trying to be as close to, if not completely stone free, they need to go into it understanding that this may take a couple of treatments to effectively do that based on the stone size and the location. Of course, you have your traditional ureteroscopes. I would counsel them that there is, at least in my practice, probably about a 5% chance that in a primary ureteroscopy never been instrumented, let's say this patient is, that the scope just may not fit up the caliber of the ureter. We're not going to be forcing things. We can certainly do certain gentle dilation techniques, but at a certain point, the anatomy is telling me if it's going to fit or not, especially with our digital ureteroscopes, which is my practice to use an 8.5 French digital ureteroscope. And I would go up there, I'll have, obviously you have your wires. I am a duster by practice. And for those that may not be aware, that's the distinction between, are we going up there and fragmenting versus plucking out pieces? That's usually going to be done in a case like this with an access sheath. So that's an option you have if you want to do, but a 1.5 centimeter stone is gigantic as far as stone pieces that you're going to want to be plucking out. You're going to be there till the cows come home. And we've all done those cases. Whereas if you're dusting, there's evidence to suggest that where it may feel like it's more painful because you're doing more work, really, in the end, if you're really doing a good job of dusting this down and then relying on the urine flow to flush it out, that you'll actually be more efficient in the end, and also run less risk of being traumatic to the ureter with all those stone extractions. There are, of course, newer technologies out there. I'm fortunate to have access to a few of those that I can touch on. These are the suction-based technologies, which are rapidly taking over our subspecialty right now. And I would have at least one of those available to me to help give a better chance of rendering this patient stone-free in a single procedure.
Yeah, absolutely. And what type of laser do you use? What's your preference of laser type and settings?
Yeah. So in this case, where I'm going to be approaching it from a dusting technique, I prefer the thulium laser. That's the thulium fiber laser, typically using a 200 micron optical fiber. The fiber size, typically in a ureteroscopy in the kidney, you're using a 200, sometimes as small as a 150. The 200 just works really well because for a lower pole, you have to worry about the size of your fiber because that's going to impair the deflectability of your scope if you're going too large. It's also going to impair your flow, which is already going to be critical here. You can imagine it's going to be like a snowstorm in there. So you're going to want to make sure that you choose your fiber. You can use the smaller 150 micron fiber for the thulium, which is nice. But a fair part of warning for patients, for physicians who use it, I believe it's a maximum of 25 watts in power is what you can use, which frankly, we're not going much above that in our ureteroscopies anyway, but just something to know that you can't really go much above 25 watts before it'll fail. And then as far as settings, I find the thulium just to be a dusting platform regardless. So I feel like a lot of those settings that we learn about fragmenting versus dusting with a holmium, I find they don't extrapolate as well. I typically start at about 0.5 joules and 40 watts. That gets me to 40 hertz. That gets me to 20 watts. That's usually my starting point. Then I'll kind of adjust as I go. I kind of get to the highest energy where I have the nice small fragments, and then I'll go up on my frequency till I get to a speed that's as fast as I can go, where I'm still in control.
And then I'll ask my last question. I got to ask one more question from a non-endourologist. So you finish your ureteroscopy on this patient. Let's say you take him, you do your ureteroscopy, you get him stone free. You're gonna generally leave a stent on this patient.
I am.
I was gonna say, what's your stent practice? Do you leave it on a string? Do you have him come back in a week or two and take it out with a scope? How long do you like to leave it?
You could have fooled me that you're not an urologist because you know all the hot topics. We're not very exciting, but we like to talk about stents and lasers. Yeah, the stent, a stone of this size, likely the amount of time I'm going to be in there, I'm going to leave a stent in there. And I typically, assuming it goes well and I don't expect them to have to go back, especially in a man, I like to leave it on a dangler, a string to make it easier for removal. I'm fortunate to never have a stone myself, but I personally would probably take a string instead of a cystoscopic removal. So that's kind of the practice, what I preach, so to speak. And I think that'll just make it a lot easier for them. You can, of course, if you're doing a good dusting, you can, of course, leave these patients stent free. And a lot of people are doing that. And there's a lot of now, there's actually a great trial out west led by Seth Beaches at San Diego, who just showed that even with access sheaths, many patients, if they're uncomplicated, you can leave them stent free without any difference in outcomes. I'm a little risk averse to the call in the middle of the night. And I think the few days of assurances that the stent is in, especially it's on a string, I can just remove it in a heartbeat. It's not easy to put one back in.
Right. So it's usually a matter of days, less than a week.
Less than a week. I mean, it's typically like in that 3 to 4 day range. I operate early in the week, comes out by Friday. Alex, what are you doing as far as stenting?
I love the stent on a string, but as I tell our residents at Monty, don't use a string unless you're willing to have that stent get pulled out in 10 minutes in the recovery room. So if that's a critical stent that you cannot lose, if it's a solitary kidney or a stage procedure or a ureteral injury, I'm not using a string. But on the flip side, I really like strings. I think it's much more convenient for the patient. They're not really at higher risk of complications or UTI or infection. They tend to tolerate the strings well. So we're definitely doing that. But as you mentioned, I'm definitely pushing the limits of who can be left unstented after ureteroscopy too, because for the patients, for us, the doctors, stents are the bane of the existence of many a urologist. And for every call you don't get in the middle of the night from the patient obstructing, you're getting double that amount of call from patients with stent colic. Now, you mentioned early on that you would do PCNL on this patient. Can you walk us through your access technique?
Yeah. So I'll mention, for a stone like this, lower pole, this size range, this is probably someone I'm going to do a miniature PCNL on. So my access, it's a little bit interesting story how I got here. I was trained traditionally with a prone access under fluoroscopy triangulation. In practice, I've largely shifted a little bit. You could say I maybe drank the Kool-Aid a little bit in the field about some differences. So these days, I'd say 90% of the time, I'm doing this supine with a combination of ultrasound and fluoroscopy to gain access. And this is someone I'm probably going to go right into that lower pole. Depending on the anatomy, it may even be into a mid-pole calyx if it's not too sharp of an angle between those calyces to get in safely. I find the supine is just the angling of the calyces relative to the rest of the collecting system. You're often afforded a lot more movement throughout without torquing too much, unlike prone access, especially for a lower pole stone. The kidney is tilted posteriorly, and therefore getting lower pole, it's literally the most anterior part of the kidney. So it can be challenging if you want to get right on the stone. So I'll get access in there. I will typically, after confirming I'm in, and I should mention, the whole ultrasound versus fluoroscopy thing. I don't have things like a needle guide I have access to. I do have these patients rotated approximately 20 to 25 degrees while in a lithotomy position, such that the ipsilateral side is up on some bolsters. I like to get an ultrasound even before I drape them. I want to just kind of make sure, did anything shift from that preoperative CT? Is there going to be anything in the way? Do I need to maybe rotate this patient more instead of kicking myself when I'm in the case? just to see that, okay, I have a safe window. And then when I'm actually going, I use the ultrasound to at least horizontal to the ground to kind of just tell me, where is my calyceal line? Like, where are the calyces themselves? I sometimes, when I'm teaching it, because I have the residents try first, I will use a marking pen to kind of just draw that line so they see that's like the A line. Like, that's the line that they want to be aiming for, horizontal to the ground. And we sometimes will just go access sonographically, but you can also combine that with fluoroscopy, where you can find the angle you want to aim at along that horizontal line of the targeted calyx with our simple retrograde pilogram, and then you generally stick it right in, and within a second, almost always you're right in with a little modification. And then in this case, I typically use a 16 French suction renal access sheath for my mini PCNL, which is a single step dilator. It doesn't require balloons or anything like that. You don't really need to incise the fascia or anything. It's pretty atraumatic. And then I'll use I know I'm going beyond what you asked with the access, but I'll break up the stone in this case with a laser, and then just try and suction pieces out as I'm breaking it up. Is that how you get your access as well, or?
Yeah, I do something very similar. I'm about 50-50 prone versus supine at this point. I absolutely love the ultrasound for the puncture. My residents say the ultrasound is the cheat code for PCNLs because you can just so clearly see exactly what you're doing and exactly where you're going. So,
and just like a safety perspective, even if you're not yet comfortable getting the access,
absolutely,
you have that assurances that there's nothing lying in the way, especially in a supine case where you can definitely start to run more into viscera.
Absolutely. How about for standard PCNL? What size are you dilating to, and what are you using as your lithotripter?
Yeah, so my standard is a 24 French, with a balloon. And so when you do that, the caveat is that you have to, I have like one of those nephroscopes where the outer sheath is 26, so you have to take it off. So you have to, of course, be careful passing instruments in. That's a pretty common modification I think a lot of people are doing these days. I'm getting the sense you do that as well.
I do. Pretend Dr. Anderson here is the patient sitting in front of you, and he opts for PCNL. He says, "Great, I want to maximize my stone clearance. I want to do this in one shot." What are you telling that patient are the risks of PCNL?
Yeah, I mean, I start with the risks that I've been saying since I was an intern, which is infection, bleeding, injury to nearby structures. I mean, I think we all can kind of spit that out pretty quickly, and then you cater those to the specific surgery. So, an infectious risk probably runs on the order of, it's maybe it's quoted as high as 5%, probably with any endoscopic urology procedure. Bleeding, of course, is one of those risks that's important, especially with a PCNL to mention, because that's one of the big distinguishing issues compared to your uroscopy, where the bleeding risk is almost negligible. I can't really remember a case where you end up needing to send someone to IR after a ureteroscopy. If you look at the literature, like the Crow's data out of the Endo Society, it'll quote some pretty high numbers, maybe on the order of like 10, 12%, which I don't really believe, or I don't know where that data comes from. I think most people who look at their own data, if they do these at high volume, it's low single digits where we're talking bleeding to the point of needing a transfusion or God forbid, an embolization. So I probably quoted somewhere like in that up to 2% risk, 1% to 2%. And then the other major thing, of course, is we're percutaneous. So now we're in the space of visceral injuries, pleural injuries, and things like that. That's where a lot of, that stuff we were talking about with the value of ultrasound, whatever, is useful, but it's still not, it's not zero. It can't be zero when you're doing something percutaneous, things happen. So while those are kind of more on the orders of the 1 in thousands of cases, it's still a possibility that you have to discuss carefully and be very, judicious with when you're offering a percutaneous treatment.
In those rare 2% of cases that you've experienced where there have been significant bleeding, how do you manage the intraoperative bleeding, and what's been your experience with identifying and managing postoperative bleeding?
Yeah, so between those two things, I'd say when it comes to bleeding complications, the lion's share is postoperative bleeding, kind of that 1 to 2 week range, a lot like you'll see with partial nephrectomies. Intraoperative bleeding, it's kind of just following your usual principles. It's pressure. So it's, usually it happens with the access, or when you remove the access at the end and you're like, wow, the tract is really bleeding. The first thing is to not panic. They're not going to bleed out right in front of you. You want to take a second. You want to just put something back in that tract and then take a second and breathe, just like you would if something was bleeding in a intraperitoneal case. So if you can get your sheath back in, that's great. You put a finger in there. They do make special balloon dilating catheters that you can send someone to the recovery area on the floor called a K tamponade catheter. That's also an option. A Foley catheter, you just grab something, inflate the balloon with 3 to 5 cc's, excuse me, pull it on some traction, and some pressure dressings. And that'll usually control it, and then you can kind of see what's going on. And then in that early postoperative phase, you can monitor the labs and vitals. You can slowly take down the pressure of the balloon to see what's going on. You may need to coordinate, with a CT angio where you take it down under imaging to determine if it needs embolization. And it's a similar principle to any kind of post-op bleeding on the post-op end, where it starts with, get that patient to the ER and in-house, some bed rest, transfuse as needed, consider, CTA versus direct to IR. That's a whole other debate in of itself. Generally, as long as you make the patient aware of these risks and they're communicating, getting in quickly, they're going to do okay.
So PCNL is a slightly higher risk surgery than a ureteroscopy is. What else do you prepare your patients for surgery any differently for a PCNL than a ureteroscopy? Meaning, are you doing type and cross on them pre-op? Are you getting a bunch of labs on them? Are you having them seeing, getting medical clearance and cardiac clearance and so forth?
Yeah, they're all getting a medical and or cardiac clearance as needed anyway because of the general anesthesia required. But you make the good point about the other preoperative evaluation. I mentioned that everyone gets a CT, but as far as like lab work, I don't typically get coag studies, for example, on a ureteroscopy. I really only get it for the shock wave, of course, because it would be a contraindication if there's an abnormality. And of course, a percutaneous procedure. To tie back a little bit to guidelines, the guideline panel, they actually align a lot with the American Society of Anesthesiology, wherein they don't advocate a routine standard workup for every patient where everyone goes for coags. It feels like that's sometimes how we evaluate our patients, but they don't. And they even say in a percutaneous procedure, like you just reserve it for someone who's had a higher, they have a history of bleeding risk or some others, bleeding abnormality or coag abnormality. But that, of course, may easily be superseded by your hospital policies and your anesthesiologist. So to steer back to your question, like this is someone who's definitely going to get coag studies. If there's anything that seems a little bit off or concerning, I'm going to be very mindful of whether or not I want to offer them the percutaneous treatment.
And you brought up the guidelines here. We spoke about the guidelines a few times. This is not exactly a guideline, discussion, but is there anything that you do slightly differently from the guidelines? They're usually very clear about the recommendations as far as stone location and size. What do you think is slightly different in your practice from what maybe if anything, from what the guidelines recommend?
They are very good about leaving room for interpretation. They are just that. They're not rules, they are guidelines. And I think even where we're talking now with like the size of the stone here, this 1 to 2 centimeter range, yeah, I will, as an endourologist, I do a lot more percutaneous treatments than someone who may have not had, fellowship training in that, for example. So that's definitely one place where I will. I also am just much more liberal with the use of CT scans. You can schedule your shock waves under KUBs and ultrasounds or even your ureteroscopies, but I just like to have a full detailed thing. So that's where I'm kind of bucking the trend a little bit in that I want to have the CT. I just want to just know exactly what's going on, really characterize that stone burden. So that's off the top of my head. That's really the two main places I would do. I don't know if, for other endourologists here sees differently.
Well, speaking of the guidelines and imaging strategies, what's your imaging strategy to assess for residual stones after stone surgery? And not that you have residual stones after stone surgery. I'm sure you never do.
Of course not. No, I typically, this is a place actually there are no guidelines on, at least not currently. I typically will get an ultrasound at about that 1 month, 4 to 6 week window postoperatively. Usually that aligns well with, I've already taken out their stent if they had one and they're doing a, metabolic testing, 24-hour urine testing, et cetera. So it all lines up nicely to that first visit. It's an ultrasound plus or minus a KUB, depending on the the radio density of the stones, if it was a shock wave. On occasion, I will get CTs, and that really is more guided by what were the goals of that patient. Like if that's a patient who absolutely wanted to be stone free and would be willing to undergo more treatments, well, then we should be getting a CT because that's going to be the most accurate tool for understanding if we have residual fragments. The ultrasound is critically important, for understanding residual fragments, but really that risk of silent hydronephrosis, that obstruction that's rare, but because it's asymptomatic, it can lead to renal demise if it's not caught. So we want to do that. And even though there's no guidelines on which of these tools to use, it's generally recommended that you do something in the post-op phase. And I think most people are falling somewhere probably in like that 4 to 12 week window.
Yeah, that's great. And now, without delving too deeply into the medical management and metabolic workup, because that's maybe going to be a whole podcast episode in itself. Generally speaking, when are you doing a metabolic stone workup? What are the big things that you're looking for? And, when are you deciding to send someone maybe to a nephrologist or escalate them to preventative medical treatment?
Frankly, I offer it to the overwhelming majority of my patients. I mean, you have to kind of, contextualize that I am an endourologist, and I run a stone practice. So of course there's it's a little self-serving that everyone there is motivated to do treatment for medical prevention. So the majority of people will get it. And I typically will do I always did a 24-hour, like a single one initially. And then I've more recently switched to 48 hours by convincing of some of my partners. Actually, one of them, to answer your question, is a nephrologist. I typically do a lot of the medical management and prevention myself. I do have a partner now in the nephrology department who's very motivated and wants to do combined. And we recently have actually established a true multidisciplinary clinic in the truest sense where, just earlier today, he was in the practice with me all day, and we kind of stack up our medical patients to see them together. And it's very useful to kind of hear, even if you're someone who does this a lot, to hear the other side of it and how things are taught from a medical side. It's very useful. We have dietitians on faculty. It's a little bit more challenging to get patients into them, more so because it's an insurance coverage issue. If you have things like diabetes or other kind of competing comorbidities that also complicate a true diet they're supposed to follow, you can sometimes get around that a little bit. But it's nice to leverage everything you have available, even if you are someone who you think, your medical stones.
Jared, this is Gina. This has been very enlightening. I think you kind of bridge the gap between basic foundational knowledge in endourology and approaching this, borderline case, and really delved into your own practice patterns and some of the nuances. So I think that this podcast will be really valuable for our listening audience. As you reflect on everything you covered over this time period, what would be your takeaway messages, say for trainees, maybe when deciding between S-wall or ureteroscopy or PCNL? What are some key messages you'd want people to know?
I'd say that there's a lot of options in stone disease, and there's really, despite what some people may say, there's no quote unquote right way to treat this patient's stone, or really any stone for that matter. You really need to consider all of the factors as we've been kind of speaking on them and laying them out here today, their relative risks and benefits. And you mentioned the ESWL. Of course, it's not a first line option in this patient. Doesn't mean it's not an option. And therefore, that's where patient preference is really so critical in the decision making.
Any other high yield points, maybe things that you learned the hard way your first couple years in practice and approaching these seemingly straightforward cases that you'd want other people to have the advantage of knowing?
Yeah. Well, for one, I would say really get to, as you go through your training now and even later, like really get to know your equipment inside and out. I really always approach these like stone cases as a bit of a problem to solve. And there's often some wrinkle or unique complexity that makes it different from not every other case you do. And therefore, you have this very finite set of tools as an endourologist. And it's kind of the fun and the challenge of it is kind of picking and choosing amongst those tools to kind of get the job done, not just effectively, but efficiently. I'd also add, like, I always tell my trainees, like, it's really important to trust your hands and learn to trust your hands. Endourology is so much about that haptic feedback. We're doing a lot of stuff under fluoroscopy with poor vision in some of our scopes. And you really want to know what are the limits of what you can do, what doesn't feel right, and learn to trust those hands. And then the last thing I would say, especially reflecting on early practice, especially for people who may be heading into practice, and this is probably applicable to any subspecialty, which is, you come out of training, especially if you do a fellowship and you're like, I'm going to do all these things and I have all these great little iterations and I'm going to do supines and prones and minis. And then you get there and you're like, you have a whole new team. You're not in your comfortable environment with your fellowship mentor who's been doing something for 30 years and has like this perfect system, so you have to be patient, and it's probably best to just kind of keep it a little simple at the start. There's a learning curve to just being and attending, and even for your team. And if you're jumping around too much, you're not going to learn your preferences. So what I learned maybe a little bit the hard way, and I've kind of course corrected, is like the first little bit, kind of keep it a little bit simpler, even if you want to be doing more. And then when things are kind of humming, then you kind of start adding those bells and whistles to your practice until it looks like you want it to look like.
Well, that was excellent. Jared, thank you so much for being with us today. We appreciate your insights and your expertise, and we think this is a very valuable discussion to help some of the trainees and urologists learn more about management of a lower pole stone, a very common scenario that we all see, and gain a little insights into how an expert thinks. So thank you very much. Thank you for joining us on this episode of Behind the Scope Empire Urology Clinical Case Conversations. We hope our discussion enhanced your understanding of the clinical decision-making process of this high-yield topic in urology. Please subscribe to our podcast and check out other episodes on the Empire YouTube channel.